Good evening, friends, and welcome back to the Thursday evening teaching sessions brought to you from Lokmanya Tilak Municipal Medical College, Sion. We once again thank all the authorities at Sion for allowing us to conduct these classes here, and we thank all our online viewers and our faculty for joining in. Today, again, we'll have the case presentation by Dr. Payal, followed by a revision on growth charts by Dr. Tushar Maniar. So we'll start with the case first.
Good evening, sir. Asim, 2.5-year-old male child, fifth by birth order, born of non-consanguineous marriage, Sheikh by community, Muslim by religion, resident of Kurla, hailing from UP, Uttar Pradesh, brought and informed by mother, being reliable, with chief complaints of cough since 8 days, fever since 4 days, increased work of breathing since 2 days, not pass urine since 1 day, and altered sensorium since night before admission. Child was apparently alright 8 days back, then started with cough, insidious in onset, initially 2 to 3 times, which increased in frequency to 10 to 12 times per day, productive, more during night time, not responding to symptomatic medications, and not associated with post-seizure vomiting. Also, child had started with fever since 4 days, subacute in onset, gradually progressive, not documented but low grade to start with, and increase over 2 days to moderate to high grade. Child was less active in interfebrile period. It was temporarily responding to symptomatic medication, and it was not associated with rash, burning micturition, or diurnal variation. Also, mother has noticed increased work of breathing since 2 days in the form of increased rate and depth of respiration, for which she had approached a private clinic, and their child had received twice nebulization per day on OPD basis for 3 days and some medications for fever and cough. Child had not passed urine since yesterday 10 am, also decrease in oral intake since yesterday. Since night around 11 pm, child had altered sensorium in the form of increased irritability, increased preference to sleep, and in the morning, mother had taken child to some private hospital from their parents were told that child had some brain infection and advised to take him to higher center for further management. Within 1 hour of admission to our hospital, child had one episode of paroxysmal event in the form of uprolling of the eyeball with tightening of all 4 limbs with no deviation of angle of mouth or no bladder or bowel incontinence. It around lasted for 10 seconds, and we subsided it by injection midas. Child has a history of COVID in father, COVID RT-PCR positive 5 months back with no other complication except loss of taste for 7 days. There is no history of TB or TB contact. There is no history of trauma, no history of any ear infection or chronic suppurative otitis media, no history of any recent febrile illness, no history of vomiting or any focal involuntary movement or any signs suggestive of space occupying lesions. Past history is not significant. There is no history of previous hospitalization or previous any major surgery. ANC wise, mother is not registered, not received any supplements throughout pregnancy. Only injection TT was received. 2 USG scans were done, which said to be normal. Birth history: birth is full term normal vaginal delivery, home delivery. Birth weight was around 3.5 kg. Baby cried immediately after birth and received birth vaccination. There is no history of any NICU stay. A child is immunized till death. Developmental wise, a child appropriate developmentally for age. Dietary history wise, diet is deficient in calories around 20 kilocalories, and protein intake is good. Family history wise, there is history of first birth at 4 months of age, sudden death, quarry aspiration, and also one girl child at day of life 3 aspiration, quarry aspiration, death. Otherwise, birth history is not significant. Socio-economic history wise, child belong to lower middle class of modified Kupuswamy scale. My provisional.
So basically some mild cough for 3-4 days followed by fever, and 2 days after the fever altered sensorium, right? No, 2 days after fever increased breathing, increased work of breathing,
Followed by not pass urine since 1 day and altered sensorium before night of admission.
so it is 4 days after the fever altered
Yes, ma'am.
sensorium.
Yes, sir.
Yeah. So what do you think of this sequence of events? So first thing is, what I want to know from you is, what do you think? This is a viral infection or a bacterial infection or non-infective? And then second, I want you to think about the possibilities of altered sensorium, because it didn't start with that kind of a illness. Getting what I'm saying? Okay. So what do you think? It's viral infection or bacterial infection to start with? Come on, some thoughts. So what does a lobar pneumonia start with?
It starts with productive cough, then followed by fever, high grade fever, and not active in interfebrile period, so more of bacterial etiology.
In this child you are saying?
Yeah, yes.
Okay. Any other thoughts? So typically pneumonia, what is the first symptom usually? Fever. So here this child already had some cough for a few days. So that's a little odd to call it a bacterial infection to begin with. Okay, of course we need to be very clear whether the history is accurate, whether there's past history of reactive airway disease, so many other things. But generally a bacterial infection starts with fever. Okay, so that's one point. Now, after 2 days of fever, increased work of breathing. What does that tell you?
Progressive course of the disease. And
So progressive course of the disease is right. Now, suppose we discount that cough for the first 4 days, then fever high grade, and then 2 days later increased work of breathing. Does it fit in with a pneumonia? Story of pneumonia? Yeah, it does fit in with a story of pneumonia if you discount the initial cough. So we need to be very clear about that part of the history. Okay? Can it be a viral infection? Can they become breathless later? Why should a viral infection become breathless? Think, try, whatever.
viral URTIs can precipitate some bronchospasm, hence.
Okay, so a viral infection can trigger a reactive airway disease. That's one. What else?
Viral pneumonia.
Viral pneumonia. What else? So here they also described that the child had not passed urine, etc., and decreased oral intake, etc. So which means the child was getting sicker, right? So it is unlikely to be your reactive airway disease spasm. And what other question will you ask along with this? So with this increased work of breathing, what happens to the cough, and what means, is that important? If the cough worsens badly, that means it's a airway or a interstitial disease, and if the cough doesn't worsen, then it's probably a bacterial pneumonia, because in that the cough will come up later, right? So these are the different things that you think of.
I think always start with the first symptom and think what you would have thought of before the second symptom comes, because there is a gap between those. So if the story starts with cough, you need a lot of more information on cough, like an undergraduate, dry or a wet cough. How severe the cough? How significant the cough? Has there been anybody else coughing in the family? Has there been a past history of similar cough? Unless we know all that, we will not know whether the cough is an insidious onset of no significance or it has a great significance. I think we must make a habit of doing all that origin, duration, progress each time. Now you said that everything was all right before that, but a specific question, has he been off and on coughing? No, for parents, oh, that's normal. So when you ask, has he been all right? Yes, he has been all right. Has he been healthy? Yes. But he could have had hyperreactive airway disease of whatever kind. So you start asking all these details and then come to a probable conclusion in this situation that the cough was probably insignificant in this whole story. But you can't just throw away that cough, because cough is the reason to start with. So for a while, without knowing many details, we will keep that cough away for a while, as Rajesh said. But for that, we must know all these details. Then comes fever, okay, and possibly we may consider that was the beginning of that story. But 2 days later, there was increased work of breathing. Now, the parents don't tell you increased work of breathing. In the history, you must tell us what did the mother exactly say. Probably mother said that there was tachypnea. Now, you interpreted it as a work of breathing. Now, it could have been no work of breathing and only tachypnea. Is it possible that somebody has a tachypnea but no increased work of breathing? After all, there has to be increased work of breathing. No, if you are tachypnic. So can tachypnea be without increased work of breathing?
In the acidotic breathing.
Acidotic breathing. Yes, very good. Excellent. Anything else? You are right. So one is whether it's an acidosis, and the other is it a symptom or a sign of a higher brainstem irritation? Okay, just tachypnea. After all, the control of breathing is coming from up there. Is that the first symptom that is telling us that the whole story is moving to the cranial cavity? So keep a note of that. Increased work of breathing is fooling us because we are thinking whether it's a pneumonia, etc. It could be. But my point is we need to be very sure about tachypnea with or without increase. Now tell us why metabolic acidosis has no increased work of breathing. I thought tachypnea is an increased work. So what is increased work of breathing? Is breathing a work? Then I say I'm working all the 24 hours. So what do you think?
Accessory muscles, respiratory accessory muscles will cause the increased work of breathing.
Correct.
Yeah.
So sir is asking first what is work of breathing? Why do we use this term that breathing is work? Who is working?
Accessory muscles.
Accessory come later when it is increased. When it is normal work of breathing, who is working?
Diaphragm.
And
Intercostal.
intercostals, right? So now sir's question is, why is there no increased work of breathing in acidosis versus increased work of breathing in a pneumonia? So what's the difference?
So in acidosis, the lung function is normal. Otherwise, the other parenchymal disease, airway disease, the lung function is not, the lung is not working, either parenchyma or airway. So the muscles has to work for that.
Good. So what we mean is that normal process of breathing is very subconscious level. You don't have to remember, you have to breathe. But when you say work of breathing, that means you are making more effort to breathe. Why are you making more effort to breathe? That means either there is an oxygen going in less or a CO2 coming out less. And how does that progress further? Chest retractions, etc. So work of breathing means that you are making some extra effort to breathe. And why are you making extra effort? Okay, I came just a minute after 6 today. Okay, normally I'm here 10 minutes before. I was held up in a traffic. I had to increase my speed, increase work of walking, because I had to come here on time. Increase work, but normally also I work. So that is important to find out, whether it was a cerebral irritation. Sometimes the cerebral irritation of the higher center may just start with tachypnea and nothing else, and if you don't take an account all this that we are discussing, then we are waiting for a seizure to come or unconsciousness to come. Now that is how it is. Okay. Otherwise on the story looks like pneumonia. Now how often you have seen a pneumonia a day or two later coming with a neurological complications? Give a thought to that, because quite a few have had 2 years, 3 years of experience seeing maybe 10, 20, 30 pneumonias. How often they land up? If I ask you what's the complication of pneumonia, you will say empyema, you will say lung abscess, okay, you will say respiratory failure, but you're unlikely you say a meningitis. On the other hand, if you have seen meningitis, how often they develop pneumonia? Now tell me, why does this not happen? It may happen any time, yes, okay. If you are an immunocompromised patient, if you are a malnourished child, yes, the whole. But before that happens, the infection will spread to the organ completely. Like it could be a bilateral pneumonia, extensive pneumonia, before it goes somewhere else. Why does this not happen commonly in a bacterial infection, that you get two systems involved? If we understand that, then we will say, no, this can't be pneumonia with meningitis. Either there was no pneumonia at all or there is no meningitis at all. Then we will see how pneumonia can cause neurological problem without infection, and how can a meningitis encephalitis can start with tachypnea. We can combine that. What's your first impression? Give a thought.
So, to give you another clue, suppose you were to see differences between bacterial and viral infection generally. What are your words? How do you differentiate? Bacterial infections are dash, viral infections are dash. Very good. Bacterial infections are localized, and that is why going from one organ to another organ is uncommon. Rarely it may disseminate, that is sepsis, but that is under overwhelming circumstances or whatever. So that's why bacterial infections are usually not in two organs. So pneumonia with meningitis is not so common.
So now discuss, can pneumonia, this must be pneumonia, can it have a non-infective complications in the CNS? Infective, unlikely. So non-infective complications.
So which means all these symptoms like altered sensorium and irritability and preference to sleep could also mean what? Do they mean meningitis only? What does it mean? What word will you start with as a broad word and then come down? One word to describe all this?
Encephalitis.
Encephalitis or
Meningitis.
encephalopathy. So you will say this is encephalopathy. Now this could be metabolic or otherwise. Metabolic as in, so how is it related to that respiratory problem? What could have gone wrong? What electrolyte problem?
Sodium imbalance.
Very good. So sodium disturbances, hyponatremia. What else? What will the respiratory problem first lead to?
CO2.
Hypoxia. So whether it is just hypoxia, then of course if it is CO2 retention, then what else? So now if you have to differentiate all this, can you try and go deeper in the history and try to get this? Is it that respiratory problem has led to hypoxia, which has led to altered sensorium?
Would acidosis do that? You said metabolic acidosis. Would it cause encephalopathy? Yes. Okay. So many ways it will happen. So we keep that in mind. Another way, could an intracranial problem start with tachypnea? We have discussed all that. Okay. But that doesn't last for a time. That is just for some hours maybe or a day that you might miss irritation of the higher respiratory center. But it does not go on and on for a long time. So that is less likely. Okay. So we will keep all these options on. Again, one thing that worries me is that there is altered sensorium in the form of irritability, but also it says he prefers to sleep. So we need to be very sure what it is. It could be both are likely. He's irritable for some time and then he goes to sleep. Okay, or wakes up and become irritable again. Yes. But irritability and excessive sleep don't go together. They could follow one another, each other, but not together. So again, a point to ask in details.
Next. What happened next after this? Then there's a paroxysmal event, right? So now what does that mean? What does that mean to you?
What are the causes? What are the likely situations where somebody can throw a seizure when you are dealing with a respiratory problem?
Okay, hypoxia. Then
Hypoxia, okay.
speak in the mic.
Sir, hypoxia and sir, electrolyte disturbance. Like we are
Very
already ruling on the hyponatremia and the calcium can be there, hypocalcemia, and sir, underlying infection can be there, meningitis, encephalopathy.
Okay.
Fever.
Just fever itself, very good. Like febrile seizure, you mean? Okay. Anything else?
Can it be encephalitis? So what are your thoughts on this becoming encephalitis now? Infection has spread from the viral infection has spread from lungs to CNS. What do you think? So generally most encephalitis are by neurotropic viruses. So the virus directly goes to the CNS. So you don't have an initial story and then the CNS. Secondly, there is only one seizure. Normally if it is encephalitis, then there are likely to be multiple seizures, right? So these are all your points for and against.
If you have encephalitis with encephalopathy or encephalopathy leading to encephalitis with a lung infection, sometimes you have to think about some immunological connection, like with mycoplasma. Mycoplasma can have mycoplasma infection and then it can have something in the brain. But again, the picture has to be more encephalopathic rather than seizure itself.
I was just wondering whether there's no history of vomiting. That's a little prominent, and whether it suggests that there's not too much of raised ICP and therefore it's all metabolic.
Actually, vomiting would be more for a typical bacterial meningitis rather than viral encephalitis. Okay, but here the seizure stopped in 10 seconds. Okay, it's a very, is it?
No, we subsided it with injection midas. A child had seizure
Well,
after
Midas also,
hospitalization.
but that means it was easily controllable seizure. In fact, in every hospital setting, however you are ready, it would not be easy just to start Midas and in 10 seconds the whole thing stopped. It would have taken you more than 10 seconds to get Midas on. Okay, so we'll keep a watch. What I mean is, it's a very transient seizure as it looked like. And we haven't heard whether the drowsiness, irritability, what happened after seizure stop. Suppose now she says, no, he was awake. He was not even drowsy. Okay, then takes us away from a significant encephalopathy, or it was a transient encephalopathy. So when the seizure was quickly controlled, I would be interested in knowing what happened to sensorium as well, feeding as well, whatever. Okay, so that would have, see, the point we are teaching is how important is to get into the details of this history. Okay, and if you don't, then you are totally depending on investigations. CSF, CT scan, MRI, yes. And that might confuse you. If you do not know what you are looking for, then that won't work. So that's why learn to take a detailed history and try to analyze it. It may be totally wrong. Our interpretation may be totally wrong. But that's the way to start thinking, right? Let's see what happened.
Okay, all this is not there, right? Development.
Again, one point I want to make, don't say he was deficient by 20 calories.
Yeah.
There is no one point and say, oh, I'm deficient by 1 calorie. No, it's a range, no? You could have said that no deficit. 20 is what mathematically you calculate by some formula, but that doesn't hold good for everyone. So you say the thing is normal, right? Yeah.
Sir, my provisional impression is 2.5 years old male child presented with cough followed by moderate to high grade fever spike, which gradually followed by tachypnea with altered sensorium and decrease in urinary frequency with paroxysmal event to rule out meningoencephalitis, bacterial versus viral, or other is multi-organ dysfunction syndrome secondary to underlying pathology.
So is meningoencephalitis bacterial? Is it viral?
So just now what did you say about bacterial infections? Localized.
So meningitis. Okay, but if it is localized, then why meningitis has a seizure? Bacterial meningitis has a seizure. Where is the localization? It's not only meninges, no? That involves the brain cell also. So what is your understanding about bacterial meningitis? Only restricted to meninges or also spreads to the brain cells? What about viral? Does it have encephalitis which spreads to meninges? Or there is anything else which can have both meningitis and encephalitis? Give a thought. Doesn't matter.
So first question is that in meningitis, do you get enkephalon involvement? And if so, how and why?
In meningitis, there is raised ICT. The raised ICT itself will have some problem with brain cell function. But who will get that? Younger the baby, more the likelihood. Neonate always with seizure and unconsciousness. A young infant often. A little toddler maybe. And an older child almost never. Okay? Because he can sustain that raised tension for a while without allowing the brain cell function to be disturbed. But a neonate, no. Neonatal bacterial meningitis present with seizure only and unconsciousness only. Okay. So the encephalon involvement is not direct spread of infection, but a result of raised ICT and many vascular changes that occur because of raised ICT. The brain perfusion is getting upset, and therefore you get a brain cell affection. Okay? So that's possible. But now tell us, what is a classical organism which always has meningoencephalitis? Almost at any age. Again, older age, it may be only meningitis, but often meningoencephalitis. Tuberculosis. And why is that? Because large number of brain cell problems are coming out of an immune manifestation. She's talking about immunological complication. Dr. Tushar talked about immunological complication. So TB is a meningitis with an immunological complications, and therefore you get vasculitis, okay, affecting multiple areas, typically hemiparesis or abnormal movements. So that is meningoencephalitis. Viral often is isolated encephalitis, or in an older child it could be isolated meningitis also. Two together rarely goes. But in TB, yes, in bacterial meningitis, often younger children, secondary to raised ICT and vascular issues, right? That is what is. So make it clear, yes, you are right, bacterial or viral, but you must know that this is a 2.5-year-old child. So maybe bacterial meningitis also might have led to something right up there. But the story did not start like meningitis, right?
And why do you want to say MODS? So, can anyone discuss why there is a possibility of MODS she has raised? So basically, if you start with one organ system and then as a complication you get a kind of failure of another organ system, then whether it's a complication of the original illness, that's a thought process, right? So that's why you think about it. Now whether in this case we'll strongly consider it or no, we can, it's worth discussing.
I was actually, I'm not so much in favor of MODS because there are no other system involved, only two isolated systems involved. I wanted to query about COVID because now we want to talk about MISC, everything that doesn't fit. Like previously we had season for Kawasaki, so everything that did not fit, we tried to say Kawasaki. Now we have a different version of Kawasaki. So she's given you a history. If you can just go back one slide, please. On the COVID history, yeah, correct. Some comments on this. See, anybody can have COVID and you would not know. That's a different story. Now you have a history. How does this help you in deciding for or against COVID?
Come on, any thoughts?
MISC would have a immunological reaction, and it will appear with fever of prolonged duration with rashes, GI symptoms, respiratory symptoms, mucosal involvement. So all that is not mentioned.
I'm only asking whether this history is in favor of this child having COVID, not in favor, or it's of no use.
So does the child have to be symptomatic to get COVID? No. Suppose the child is asymptomatic, you are sure child got COVID?
We have not tested, so
So we don't know anything, no?
Correct.
This doesn't really strengthen your association.
Correct. And the fact that the father had it, there is a higher chance of the child having it at that time. But then you are still 5 months away, and your MISC, how long you are, how back do you go for COVID? 3 months. Usually 3 months, isn't it? So if it is a COVID history, which is say 1 year back, then you don't consider it as a supportive evidence. One can still get MISC because of, as Dr. Rajesh said, asymptomatic COVIDs.
Now, so when you say multi-organ dysfunction, clinically you should have at least multi-organ dysfunction clinically. Here you have a primary respiratory followed by CNS, which we discussed could be even all those metabolic hypoxia, this, that. So that's not really multi-organ dysfunction. Oliguria, again, to call it renal dysfunction, I mean, it could be just hydration issue, the patient is in shock or whatever. So we don't know whether you can call it CVS dysfunction. So that's why that's a little less tenable, yeah, clinically.
So by strict definition of MODS, you can say two or more organ, like how you say bicytopenia is equal to pancytopenia. You understand? So any two or more system involvement resulting in the child becoming critical, then you say, okay, this is likely to be MODS. But what we are talking about does not fit into MODS as in multi-organ affection. You want to call the child? So should we call the child?
Baby is there.
No.
Okay, you can start presenting. It's okay. I thought somebody was sitting outside. That's
Yes. On general examination, child was examined in supine position.
Sorry, I'm interrupting. So when you present general examination here, at least, tell us when did you examine this patient? Is it today or was it before? Because we have the patient now. So now if you're going to tell me it's 91 room air, we would not have the patient here. So that is why I'm saying. Just clarify that this was the finding.
Child was examined on admission only.
On admission, okay.
On general examination, child was examined in supine position, irritable. Child was irritable child was lethargic, but whenever he wakes, he was irritable. Febrile, temperature of 38.2 degrees Celsius. Pulse rate was 112 per minute, regular and rhythmic. Respiration of 46 per minute. Subcostal retraction present. BP of 101 by 72 millimeter of mercury, near about 98 to 95th percentile. Saturation was 91% on room air, kept under O2 by bubble CPAP 99%. Peripheral pulses moderately felt, central pulses well felt, capillary refill time of less than 3 seconds, and sugar was HGT was 78 mg per dl. There was no icterus, cyanosis, clubbing, lymphadenopathy or edema. On anthropometry, child was normal for nutrition. On head to toe examination was normal, spine normal. On systemic examination, CNS wise child was lethargic, higher mental function could not be tested. GCS of E4, V2, M4, cranial nerves within normal limit, pupils were 3 mm bilaterally mid-dilated, sluggishly reactive to light. Tone was normal, power was 3/5, more than 3/5 in all 4 limbs. On reflexes, superficial reflexes present, plantar was bilaterally flexor, deep reflexes were brisk in both upper and lower limbs. There was no clonus. On sensory system, it was within normal limit. Terminal neck rigidity present. Brudzinski's neck sign was positive. Kernick absent. On parabdo examination, soft, non-tender. Liver was 3 cm, non-palpable. Spleen was not palpable. Left lobe of liver was palpable. Smooth surface and rounded margins. Liver span of around 10 cm. Other systems were within normal limit.
Speak a little louder. Huh?
So my final impression is
little far and louder.
So my final impression is a 2.5-year-old male child presented with cough, fever followed by tachypnea and not pass urine for last 24 hours with altered sensorium, with normal birth and development, with bilateral brisk reflexes and liver 2 centimeter palpable. Left lobe of liver is also palpable. To rule out encephalopathy, viral versus encephalopathy, viral versus bacterial with my second is hepatic encephalopathy and third one is COVID MISC.
So can any one of you take up the hepatic encephalopathy and discuss whether it's possible, not possible?
Physical findings, CNS yes, that's right. CNS only. And the next one? Yeah, that's right. Just integrate those things.
So what do these findings mean, sir is asking? The neck rigidity means what? Meningeal irritation. Then liver. Is it enlarged or is it normal? Come on, 2.5-year-old child. So it is a little enlarged. If you take this correctly, then it is enlarged. Liver span is enlarged. What else? Go back, one slide back. Okay. What are the findings here? Bilaterally symmetrical brisk reflexes, flexor plantars, and pupils bilaterally mid-dilated. What does mid-dilated pupil mean? So when is it dilated? When is it pinpoint?
It is dilated when the sympathetic activity is high, use of any drugs, or it is constricted when parasympathetic activity is predominant.
In the context of a CNS insult, you would have a dilated pupil when third nerve is gone. But you have to look for unilateral, whether it's unilateral or bilateral, right? It could be the first sign of uncal herniation, a unilateral third dilated pupil. And when do you get pinpoint pupils? In the pontine lesion, right? So that's the thing. So now come back to that hepatic encephalopathy. What do you think? So in hepatic encephalopathy, what is the first event? Meaning in any hepatic encephalopathy, is it encephalopathy first or hepatic dysfunction first? So is there anything in this history or examination which tells you that there is hepatic dysfunction? No, right? So that is why we wouldn't keep hepatic encephalopathy as a differential. Secondly, is there any point against chronic liver disease in this child? Any point against chronic liver disease? Growth is normal. Very good.
Could there be an acute hepatic encephalopathy?
Without
This is
jaundice.
acute. This is acute.
Yeah, without jaundice.
Okay. Is right that commonly it's a chronic liver disease worsening over time and then encephalopathy. But would there be an acute hepatic encephalopathy?
It would have presented with loss of appetite, persistent vomiting, and not more like cough, fever.
No, it won't have cough fever, so that's fine. I'm just asking first, could there be an acute hepatic encephalopathy? And if so, why should that occur acutely? And what happens acutely in medicine is what? Yes. Metabolic
Hyperammonemia.
toxin, okay. And therefore, acute rash syndrome, triggered by a virus, acute hypoglycemia, hyperammonemia, hepatic encephalopathy. But all that happens quickly in a short period of time. This is going a bit slow on all that. So then the question is, let's discuss what that liver enlargement must be. Okay, we have done this before. When the liver is enlarged, you want to know which part of the liver must have been abnormal. Hepatocyte, biliary tract, reticuloendothelial cell system, or a venous system. Where is the microanatomy of this liver? What would you say? Hepatocyte? Give a thought. Biliary tract? First tell me one of the two. Do you think it is one of the two?
Hepatocyte
No.
or biliary
Yes,
tract?
give reasons. You are right.
Because
Give reasons.
there would be a jaundice and obstructive symptoms of.
Very good. So this is not hepatocyte or thing. But don't you think hepatocyte can be without jaundice? Biliary tract, yes, jaundice. But hepatocyte without jaundice?
Ecteric hepatitis.
So in other words, not common, but lot of other symptoms. Okay. Acute, as we said, rarely. Most of the viral hepatitis have jaundice, but yes, could be. And chronic more so. This is not. So this is not hepatocyte or biliary tract. Now tell us between venous system abnormality and an RE cell abnormality. Give a thought. How would a venous system abnormality, by that I mean portal hypertension. How does a portal hypertension manifest clinically?
Bleeding, esophageal varices and.
So splenomegaly, okay, either splenomegaly alone, pre-sinusoidal, both liver and spleen with or without ascites, sinusoidal, or post-sinusoidal, often big liver and ascites. So this doesn't look like that. So it must be RE cell. Okay, if we go just by what it is. Now, what are the possible causes of an RE cell disease of the liver? What do you understand by that?
So in which kind of illnesses does the RE cell get involved?
Hemolytic anemia.
Okay, so non-infective hemolytic anemia. Then
Very good. What else?
Storage disorder.
storage disorder.
Excellent, excellent. And some infections?
Which infections RE cell gets involved?
Disseminated hepatosplenomegaly.
Malaria.
Malaria.
Okay.
Anything else? Parvovirus or EB virus. So
Tuberculosis. Okay. Right? So this could be one of those. Now, doesn't fit in anything easily on this situation. Okay. But hepatocyte disease, as you said, occasionally can be without jaundice, but not common. So we will not think about this really. So that's a bit of a surprise. What's also a bit of a surprise is she said the left lobe is palpable. Now, is it not normally palpable? Why is she saying left lobe is palpable? Every time you say liver is enlarged, so many fingers, liver span is so much. You never tell me right lobe, left lobe. Okay. She has said left lobe is palpable. What does that mean really? You get the question? You have almost never said left lobe is palpable. You have said liver is palpable. Okay. So, what does that signify? Let's believe that. See, it doesn't matter if that was not right or wrong. It doesn't matter. What does left lobe palpable mean? Is it not normally palpable when liver is enlarged? Or liver only right lobe enlarges and the left lobe doesn't?
Sir, left lobe is usually enlarged in chronic liver disease or underlying chronic pathology, but in this child with acute
Correct,
history,
I agree.
it was
I'm not doubting your findings at all. You are right. But we want to interpret that. Normally, the liver is lying obliquely and the right lobe is easily palpable than the left lobe, which is right at the epigastrum. Therefore, the left lobe is also enlarged, but prominent is the right lobe, and therefore we also percuss and find out the span from a right lobe and not a left lobe. But when left lobe typically has been very big, it happens not commonly at all, and one possibility is whether there is a congenital hepatic fibrosis. In an adult, I thought alcoholic diseases, etc., may have a left lobe, but the other reason for a left lobe enlargement is whether there is a tumor or a cyst in the left lobe. Then the left lobe is enlarged. The right lobe may not be enlarged. But here Span means right lobe is also enlarged and the left lobe. The point I'm making is, if I'm sure the findings are right, that's why you're giving it, which to my mind then, it is an asymptomatic liver problem in this child, has had nothing to do with what's happening, is one possibility. And that a disease like congenital hepatic fibrosis may not have any other symptomatology at all. Often it might cause splenomegaly also, because ultimately there will be a portal hypertension. Okay, I'm just bringing a point of a left lobe enlargement. Okay, so we are not very clear about it. And what about COVID MISC? Dr. Shah has already talked a bit on this, more on the manifestations.
Yeah, so this does not fit into COVID as such, right? At least prima facie. And the problem is you can't do antibodies to prove that, because by now most of us should have antibodies positive, even if in small or large. So we go by the criteria and see if they fit into that, which at least on history and examination they don't fit into that. But can this, so we are now hinging on that most significant finding apart from the neck stiffness has been the pupils. So can it be because of some medication that we have given that you got transiently abnormal pupils and then they became normal? We gave midazolam, right? Could midazolam have given?
Sir, injection midas was given after a CNS examination.
Suppose you would have given before a CNS examination. You should see, just because I ask a question doesn't mean anything. Midazolam gives what? Constriction. So say it loudly now. Why are you worried? Midazolam gives constricted pupil, it does not give dilated pupil. So that is out, and you haven't used any known medication, at least as of now. So that doesn't seem to be the cause. Okay. So if something doesn't fit, think about iatrogenic causes or anything they have consumed outside or have been given something else. Like, somebody has given atropine, prasad, this, that. Somebody comes with dilated pupils and you will start wondering what will happen.
I think the terminal neck stiffness could be doubtful as well. Okay, after all, terminal, even in a normal child, he is sick. You try to kind of assess. He might not like it. Okay, and you might say terminal neck stiffness. Okay, she also says Brudzinski is also positive, so I can understand that is. But the point is, if there is a meningeal sign, then there is a meningeal irritation. There is no doubt about it. Meningeal irritation usually caused by meningitis, but it could also be caused by subarachnoid hemorrhage, and it could be also caused by a tumor, posterior fossa sitting near the meninges, okay, and so on and so forth. But nothing of this kind was expected in this child. And so when you say terminal, you might also look at whether it is really there or not there. It's doubtful, because terminal, after all, this child has a seizure, he's still lethargic, he's still drowsy, and you try to move his neck or a leg, and he may not like it. Okay, and you might call it a conic sign or whatever. So that is also doubtful of that. Let's see what is.
Sir, during course of admission, a child was admitted on 10th of March. That time counts were 16,000 and lympho predominant, equally only 47 neutro and HB of 10, hemoglobin of 10.1 with hematocrit of 32.7 and counts of 168, 16,000.
Keep a little distance from the mic, but speak loudly.
On presentation, complete bleeding count, complete blood count, hemoglobin of 10.1 with hematocrit of 32.7, total counts of 16,870 with platelets of 401,000, a neutrophil of 47% and lymphocyte of 48%. On LFT, sir, on day of presentation, total BILI of 1.7 and direct of 1. Surprisingly, his OT and PT were very high range. OT was in the range of 5,731 and PT of 2,633. RFT was slightly RFT was deranged 50 and 1.4. On next day, we had again evaluated on the OT LFT range proceedingly, counts gradually counts were around same only. CBC was around same counts with OT gradually decreased from 5,731 to around 67 and 129 over around 10 days. Also, RFT gradually improved from 50 to 50 and 1.4 to 5, burn of 5 and creat of 0.4. CRP was initially raised 37.2, which gradually come down to 9. Sir, we had done serum ammonia because of altered sensorium and signs of raised OTPT range and all. So, sir, that time serum ammonia on presentation was 125. On 15th March, it was around 179. It was raised, and on 20th again we repeated. It is 128. Sir, we had done. We were thinking any viral hepatitis cause. So we have done hepatitis A IgM, Hep E IgM. Both were negative. Then. So fundus was done, which was within normal limit. Other OLD panel was negative. INR was normal 1.19. COVID antibody was sent. It came to be reactive. So we had done inflammatory markers. D dimer was around more than 3000, and serum ferritin was 705. Both were raised. Then initially, sir. Because child had convulsion while in ward on admission, that time we had given midas. It subsided, but we had then loaded with injection levera by 20 mkd, and after around 3 to 4 days again a child had a repeat episode of convulsion. That time we increased till 30 mkd. Again child had 2 episodes of convulsion, so required to increase midas around 60 mkd during the course, and after that no repeat episode of convulsion. Also, we had done CT brain. That time it suggestive of arachnoid cyst in the posterior cranial fossa. Because of repeated convulsion, we had again done MRI brain, that suggestive of an extraaxial CSF extraaxial intensity lesion in the posterior cranial fossa extending from midline to left parieto-cerebellar region, suggestive of arachnoid cyst. So we had done, because of COVID positive, we had done his 2D echo, that was normal, ejection fraction of 60%. USG abdo was suggestive of mild hepatomegaly. Because serum ammonia was increasing trend, raised from 125 to 169, we had done GCMS TMS spectroscopy study, that was negative. Then other bile salt, bile protein was done, it was negative. Other HIV, HBS antigen and HCV, it was also negative, and blood CS no growth. Sir, actually on initial presentation, urine RM was suggestive of urine protein present, urine ketone present, and bacteria present. RBCs of 8 to 10. Child during the course of admission, child had persistently high BP readings. On presentation also, BP was around the range of 98 to 95th centile, and during course also all BP readings were more than 90th centile. On presentation, urine protein present and RBC present. Also on during course, RBC is present and RBC is present. So somewhere we were thinking also kidney involvement and nephritic profile. So we had done serum complement C3. It was around 79.3, though low normal.
Chest X-ray?
Chest X-ray was normal, sir. Chest X-ray within normal limit. On presentation only we had done. So, sir, actually finding was that on presentation child had convulsion and sign of raised ICT. So we had started on antibiotic, and by default we were not able to do CSF study. So.
Yeah, I think now retrospectively we fit in everything that we said. We did say that it was not easy to fit in a bacterial meningitis. To say viral, we said that maybe the story is little slowly going further, cough and then fever and then irritability, drowsiness, seizure, and a short-lasting thing. You said metabolic, etc., when we saw the big liver, etc. So normally we would not have expected an acute hepatic encephalopathy, though we did talk about it. And whatever little I've seen, typically Reye's syndrome is a very acute onset. In 24-48 hours, the child comes with encephalopathy, with high ALT, AST, etc., and very little bilirubin or not at all. and hyperammonemia, hypoglycemia. Okay. This child apparently did not have hypoglycemia, but had ammonia. Okay. So some kind of an acute hepatic encephalopathy did occur, but did not fit in typically what a Reye's syndrome is, because Reye's syndrome is a virus triggering an acute encephalopathy. Within a short time, the encephalopathy comes up. So this took a little long time, but we are not all experienced to see many such cases, so it could still fit in. When you saw the large liver, we started thinking about that. Now, what is little, till meningeal signs, I just told you that a posterior cranial fossa tumor can cause meningeal irritation. Now, that is there, okay, which is asymptomatic. So we would not have put in all this symptomatology into that posterior cranial fossa. That is an accidental finding, but now your findings are right. Okay, we never doubted it, but we were not ready to kind of fit in this syndrome, and now we know that there is an unrelated asymptomatic arachnoid cyst sitting there, which is the cause of your terminal neck stiffness, etc. What is a little funny is that those immunological markers. So the question is it an acute immunological hepatic encephalopathy? I have no idea. We will ask our experts, our hepatologists. I think Tushar can find out. You have your hepatologist there now. To me, autoimmune hepatitis is a hepatitis, jaundice. But whether acute immunological hepatic encephalopathy, I have not read or known or heard. But we will ask our experts and tell you next time what they feel, because we are not sure about it at all. But surely there is some immunological process going on. Okay. And we don't know that. Dr. Tushar has already discussed how 5 months have passed. So, but there is still possibility whether this child got it somewhere maybe 3 months, 2 months ago, where it was asymptomatic. After all, everybody was suffering. You did not have to have a father necessarily doing that. So all those things are likely. But see, this is interesting. Okay. What we start thinking clinically and what we cannot fit. So what have we learned? When we cannot fit everything into it, there is something unusual happening. Okay. And what that unusual is, nobody would know. Okay. Today we know in Maharashtra the politics is going usually. Nothing unusual. Okay. But suddenly if they say we will do all good to the community, we will say no, it is atypical, it's unusual. Okay. So the point is, we have learned how unusual situations cannot be easily discussed clinically. And next time when you see like this, you don't first put your finger on that unusual condition and say that no, we have seen once. Because if you have seen once, it's likely you will never see again in your life. So don't repeat it, right? Any other comment?
Since we were talking about midazolam and something else which they have consumed, Dr. Palniraman, as usual, has been very active and responsive on the chat. And he has raised a point whether can it be a paracetamol poisoning coming with only raised transaminases and subsequently with altered sensorium and brain issues. Obviously, arachnoid cyst is not part of the game. It's an incidental finding. Any thoughts?
Actually, child had increase in inflammatory markers as well. D-dimer and serum ferritin were raised.
Honestly, I don't know what happens in paracetamol poisoning because we have never asked for them. I mean, I could argue that way.
So see, these D-dimer and ferritin, we have started doing them after COVID and MISC. But in any inflammatory condition, they would be raised. And there is no clear-cut level beyond this it is suggestive of MISC, and below this it's an ordinary inflammation. Such clear marker divisions are not there.
Because if you see the first reading, your OT is twice of PT. So if you see OT which is significantly higher than SGPT, then you think one of the things that you think of is a drug acute drug injury to liver, and or Wilson and chronic hepatitis.
I think I thought PT was much more than OT.
So the first report is
it?
5,000 OT
Okay.
and 3,000.
Okay.
That's what I thought. We can check it again. Rest of them are all different. So the first one is
Yeah,
5,700
OT, yeah, you are right.
OT and
You are right.
2,600. And then it is reversed back
What he
slowly.
means is OT when more than PT, the disease is not primarily
Only
the
liver.
liver but disseminated. Okay. So my worry only is that why that immune markers are abnormal, which means
No,
immune
it was
inflammation.
PT.
And we are talking about a metabolic disorder which has no inflammation. Okay, we are talking about drug toxicity which has no inflammation. So I think we are not clear, but we will get more clarification from our experts on this.
Sir, in case it was like a generalized inflammatory disorder, then the hepatic dysfunction could be part of that generalized inflammatory
I
disorder.
imagine so. For example, now, let's see how a dengue can behave. Okay, dengue can come with shock, but it could have a kind of one organ taking the brunt, okay, rather than a disseminated shock situation. Okay, same thing about Kawasaki. You can have a hepatic involvement as the sole primary concern, but of course, rest of the syndrome. So we know that every kind of a septic shock, for example, can have one organ predominantly involved rather than every organ equally involved. So we don't know whether that is still possible.
ESR, CRP, anything? Did I miss that?
Near normal or slightly raised.
CRP in the decreasing trend, initially 37.2.
Oh, last column. Sorry, I'm so sorry.
Yeah.
I was so
So
focused
actually,
on this.
that PT is 5,731 and OT is 2633.
Because
Actually,
again,
it
you know,
was
when
by
you,
mistake.
when you say your D-dimer is so high and your ferritin is so high and CRP being 37, it's also not matching. I would have expected CRP also to be very high. Because your trigger for doing a ferritin or a D-dimer would be a high CRP in a given situation of suspected MISC. We don't directly do D-dimer or here it's different. You are looking for something, you have not found anything and now you are doing it. But typically for MISC, your first thing you would be doing, or Kawasaki, you would be doing first as CRP, right?
What do you expect the liver to be now that he has improved?
Clinically.
You think liver should have receded back to normal or it's still there? Guesswork, and then 2-3 of you come and palpate the liver, the child is here. Okay. Come, just give a thought, doesn't matter. Even I can be wrong even after 60 years of doing this. Where is your shame to be wrong? You should be proud to be equally wrong.
So in paracetamol poisoning and Ray's syndrome, is it dose related or even a single dose can cause Ray's syndrome?
So let's see now. Benji, 2 minutes लेके आएंगे.
Both are there, na? I think idiosyncratic and dose related.
आप यहाँ लेके बैठो आराम से. सिर्फ इसका पेट देखना है 2 मिनट. हाँ बस. आप इसको ऐसे बॉडी में बैठो. Yeah, 1 or 2 of you come. Just palpate the liver. Nothing more. He's sleeping fine. Okay. आपका नाम बताओ. नाम बताएगा नहीं बोलता है. बराबर नहीं बोलता. अच्छा. सिर्फ पेट देखता. अभी अच्छा है ना? Very good. Very good. जरा पेट देखने दो सर.
Ask her to turn the head on this side if you find it difficult to examine. It's okay, in the exam you would want the baby on a flat surface with knees bent, etc. But even in real life, you will have to do it in the most comfortable position for the baby to start with, at least. You want to warm your hands, it's really cold here. I'll give you a hint. It's always good to be at the same level of the patient. So if the patient is sitting, you can pull a chair and be on that level. Yeah, see now he'll be very comfortable. It's okay, you can examine twice, that's good enough.
Liver is palpable about 3 centimeter below right subcostal margin. It is in the mid clavicular line. It is firm, soft in consistency. Non-tender.
When it is palpable 2 centimeters, it was 10 centimeter span. Could liver be sitting in the thorax 8 centimeters? Considering it has not gone down, what do you think? Could a liver be sitting 8 centimeters in the thorax at 2.5-year-old child? And what happens if the diaphragm is paralyzed? The whole thing goes up, eventration. Okay, so just keep in mind, sometimes the liver may not be palpable but sitting all in the thorax because you have an eventration of diaphragm or a phrenic nerve palsy, diaphragm is gone up. So keep that in mind.
Liver span is approximately 6 to 7 centimeters.
So it has gone down. But I can see the umbilicus is stretched, smiling umbilicus, ascites. Even abdomen looks a little distended. Okay. Right hypochondrium is not much distended, but overall there is a distension. Umbilicus is little stretched. There must have been ascites, which may or may not be there now. Would you percuss and just confirm whether there is an ascites, or you don't need to percuss and convince me it is there or not there, even without percussion?
Slit-like umbilicus is a clue for ascites. Then flank fullness is also a sign of ascites.
Yeah, so the point is there flank fullness?
Yes. I can appreciate flank.
Okay, do percussion.
When he actively flexes, you can see the central part becoming up. So what does that indicate?
Umbilical, paraumbilical hernia.
Correct. So it's not paraumbilical hernia. What you are trying to say is divarication of recti. Correct.
So that's why
So the
there was a central prominence more than the flank. Okay. And I was wondering why there was a central part of it. There is a divarification. Okay. Certainly it's not an ascites at all, and therefore it looks a little stretched, that's it. Abdomen is distended after all. After all, what is stretched? Any abdominal distension. This is not much stretched. So I just wanted you to know that sometimes there could be something examiner points out to you, but you are sure there is nothing, and you explain it by many other ways, right? Good. So I think he can go. Thank you. Thank you.
Does he have an edema fit? Did he have it? Has anybody seen?
She said no edema feet.
What is the serum albumin?
Sir, on presentation, child did not have edema, but persistently his serum albumin in the lower range only. Total albumin of 6 and serum albumin of 3 to 3.5. During the course, it was in the range of 2.5 to 3. That's why child has decreasing in edema, but he has developed during course.
The mother said he cannot talk. I asked her, would he give his name? I would put my mic there. He would be happy. But she said, no, he cannot talk. So there must be some damage in the brain that his speech has gone. He has no speech. बातें नहीं करता ना. What she said was नाम नहीं बता सकता. Okay. हाँ अच्छा ठीक है. Fine.
How did you treat him? Can just tell us.
Actually, sir, on presentation, child was with decreased sensorium and drowsiness, and liver enzyme were very high raised. So initially we had put on hepatic drip. Over 2 to 3 days we stopped hepatic drip. Then because of convulsion we had to put on injection Levera. Child was with drowsiness and dropping sensorium. After 1 day of admission, child had very poor sensorium. So we have to intubate child. We intubated child over 3 days of the course. Over 2 days child was intubated. On 3rd day child was extubated on CPAP mode, and then gradually nasal prongs trial child was settled well. But during second day of extubation, child had again repeat episode of convulsion, and by that on that day child had again 2 to 3 episode of convulsion. So it required to increase Levera by 60 mkd, and during the course child had persistent higher side BP reading. So we have to we were with tapering with 3% NaCl because of raised ICT sign. We had to add injection Dexa. We added it, and then other antibiotic. We have a child had initially fever spike. So initially we were in the ward. We had put on the injection zone, then upgraded to Vanco and Piptaz and Ticoplanin. Vanco was not because already renal functions were deranged.
So you didn't treat the MISC with any IVIG or steroids?
Child did not require MISC.
Okay.
Steroid was ongoing. We had given 3 days of injection MPS as well. When child had came positive with initial, we had sent a COVID profile because multi-organ involvement and history of COVID. Also it was not significant, but history of COVID and multi-organ involvement. So we had put COVID antibody came positive. Then we have given injection MPS for 3 days, and we have taken Hemat reference as well in view of adding LMWH.
Okay. Fine. Thank you. Any questions?
Good presentation.
Okay.
Arachnoid cyst is the commonest brain cyst, often present at birth.
What was the sugar, blood sugar?
On presentation was 78.
78. Okay. Because Ray's syndrome classically should have hyperammonemia, hypoglycemia, and raised aminosis. These are the 3 important cardinal features sort of for Ray's syndrome. And what is the, presentation, in the sense, what leads to Ray's syndrome? Like you said, COVID leads to MISC, so viral infection. Which virus? No, influenza. Influenza plus aspirin, chickenpox plus aspirin we all remember, but influenza plus aspirin is also important, because though more percentage of chickenpox plus aspirin will get into Ray's, influenza by sheer number being so large, that is equally or more responsible for whatever few cases of Ray's that people have seen.
It happens without aspirin as well?
We don't know.
But it was also thought that antipyretic would trigger further. Okay, it's not paracetamol poisoning, but it's already happening, and for fever you are bound to give some paracetamol or antipyretic, which would further exacerbate the hepatic encephalopathy, right?
And that is why if you read carefully about chickenpox vaccination, for all patients who are on chronic salicylate treatment, who cannot stop salicylate treatment, you have to make sure that they are vaccinated against chickenpox and of course with flu, so that they don't get that and you don't have to worry about aspirin stopping or getting into a Ray's syndrome situation.
Sir, why SGPT in 10 days can decrease to this much? What can be the reason of this high SGPT and becoming to like this low?
Why SGPT decreased in 10 days to near normal?
I think what do enzymes tell you in liver disease? An acuity. Okay. And any acute metabolic or immune mediated disorder would quickly get back to normal also. In fact, if you look at the liver function test, you have 4 interpretations coming out of it. Serum bilirubin is increased only when extensive liver disease is involved. 80-85% of hepatocytes must be involved before a bilirubin rises. And therefore, bilirubin suggests extensive disease. Okay. The ALT, AST, SGPT decides acuity. Serum albumin decides chronicity. And a prothrombin time decides the seriousness. In every liver disease, we want to know 4 things: how extensive the liver is involved, how acutely involved, how chronically involved, and how severely involved. 4 tests give you everything, right? So that's why your question is right. It also means that it was really a normal liver just a week back, and it has come back to normal, often by itself or with some medication. But yes, it could come down so fast. But when it's a viral hepatitis, okay, there is an extensive liver disease, bilirubin has gone up, okay, so it may take time to come down. And that's not immune mediated, that's an infection mediated. So infection never just come down quickly. Pneumonia will take time to go down. Defervescence is slow, but immunological, it could be very fast.
Okay, any other questions? Okay, so we'll quickly revise growth charts. Dr. Tushar Maniar will do it.
So please remind me when it's 30 minutes and I will stop. Am I audible? Okay. So let's quickly look at growth charts, because whether you take your exams, which is your all important situation, whether you are preparing a case, whether you are going to appear for an OSCE, or whether it is a Viva, or when we also discuss here each and every case, nothing goes further in your examination. After vitals, it's anthropometry. And so it's important to know that growth charts are given due importance. Okay. So what are we going to look? Once we go through this, we should know how to plot the growth charts. Before that, obviously, how to select the correct growth chart. Identify the abnormality either on a single observation or on multiple observation. You can detect various growth patterns if you have multiple readings, and how that can help you. And I have put it last, but that should come up first, because anthropometry, because unless you take the measurements correctly, your growth charts are not going to be accurate. Okay. So just quickly revising, this is an old IAP growth chart, but important to see that it shows you the age limit for which it has to be used, whether it is for boy or a girl, okay, and which type of growth chart it is. In each growth chart, you will have different types of lines which are running, and that means that the percentile lines, or whether it is an SD standard deviation lines, they will be different. Okay. So when you take a case, for example, what should you do? First, you should obviously know the patient's age and sex of the patient. You should measure weight, height and length. Finally, you should select the correct growth chart. So which is the growth chart that you use now? WHO. Okay. Till what age?
5
years. And after 5 years? IAP growth charts. And if the child is preterm, what would you use? Fenton's preterm chart. Okay. And we'll come to that, what we select. Now next thing, once you have plotted your height, you want to calculate height age. So what is height age? You all can carry 3 mics are there. Let Rajesh not do all the workouts.
Yeah,
Height on 58th centile, and we will plot to that age.
Excellent. Very good. So at whatever age this height is, the 50th centile is called the height age. That means for a given height, what is the appropriate age? That's the reverse. And what is the ideal height for age? There you don't have to worry about what is the height of the patient. You look at the age of the child and see the 50th centile. That will tell you the ideal height for age. Correct? That means that's the 50th centile value for that given age. Similarly, for weight also you will come across the same thing. This is something which we used to use previously. Observed height upon ideal height. So it's like your calorie deficit, what you calculate. This gives you the percentage deficit of height or weight. Means what is the height? Is it 90% of the ideal height, 75% of the ideal height? This gives you some idea to how to monitor. Now after doing all this, when you are taking a case, if you find that there is short stature, ideally even otherwise, because you can use that information for many other ways. But if you find short stature, make sure that you measure both father and mother and plot their height also on the growth chart, and I'll show you how. Then you can calculate the mean parental height and you can calculate the target centiles. Correct? When the patient comes next time, along with what you have done previously, you measure again height, weight and head circumference. Obviously the second time parents' heights are not to be measured, they are going to remain same, and you plot them again as new observations and try to trace backwards and connect the two lines. This will give you what is known as road to health. Okay, so that's why it's called road to health chart. Obviously, when you make any measurement or examination, you will explain to the patient what is important or not important about it. So what is the mid-parental height, also known as target mean height? How do you calculate for boys and how do you calculate for girls?
For boys, father's height plus mother's height plus 13 divided by 2, and for girls, father's height plus mother's height minus 13 divided by 2.
Perfect. So that will give you the mid-parental height, and when you get mid-parental height, again mark it at the 18 year or the rightmost line, vertical line which is present. Now what is the target range? Plus or minus
6.5.
6.5. So there is some variation on that. Previously it used to be plus or minus 8 centimeters. The new measurements say 7.5 or 6 centimeters, depending on what you follow. But important to know that this gives you the target range. That means what you have drawn on this side, you have got a mid-parental height. Then you have drawn 1 and 2, plus or minus 8, for example, if you take, you get a target range. Now you draw the two lines parallel to the percentile lines backwards. It gives you the target centiles. Okay. And the important point is that target centiles correspond to 3rd and 97th centile of that particular child. Just to give you an idea, WHO growth charts are so good because they have taken sample size from 5 different continents and they have averaged it out. They have taken as ideal growth, they are ideal growth charts. Okay, there is a difference between reference growth chart and ideal growth chart. What is ideal growth chart means? They have taken singleton child, not twin pregnancy. They have taken children of mother who is not smoking. They are from a reasonably good socio-economic class. There is no congenital abnormality in the child. With all that, the reference, whatever measurements they have got, they have prepared the chart, and that's why it's called the ideal growth chart or the target growth chart. Means this is what we want our children to be. And on the other hand, reference growth charts means you go in a population, take cross-sectional measurements of different children and you prepare a chart, and that will give you what is the current existing situation, and depending on that whether your patient is falling into that or not. Okay, so that will give you comparison with the whole world. Then you do IAP charts because you want comparison with your own Indian population. And if you go to say somebody has Turner syndrome or somebody has Down syndrome, then you follow their charts because that will give you only that narrow normality. Now if you do target centile, that gives you the specific centile lines for that particular child, because depending upon the growth potential of their parents, you are getting the percentile measurements. Okay, so that's very specific. Just give you a graphic presentation of what I have said till now. So you have, for example, taken two measurements. You can see those red dots. Two measurements you have taken. Now you have taken father's height and mother's height, and you have got a mid-parental height. So you can see that green dot on the right hand side corner, right there, next to 175. You can see that's your mid-parental height or target mean height. Now you have got plus or minus 8 centimeter, that gives you your target range. Clear? Now you draw two lines parallel and trace it back. So this gives you your target centile. So at any point in time, if the child measurement is within this, then you are almost always sure that this child has been thriving well or has been growing well. Okay? So let's do this little bit of exercise. Always remember that you get weight for age, height for age, and weight for height. Correct? So you do height for age for chronic. Very good. And weight for age for? No, weight for height for acute. Right? So now let's look at this. You have a weight for age is normal, normal, normal. The child is normal. What is the second one? Weight for age will always be decreased, correct? Only then you are thinking about malnutrition. So let's not look at that one. Now you have height for age which is normal, but weight for height, is decreased. So what type of malnutrition is this? Acute malnutrition. Perfect. Okay. The second one is decreased weight for age. Obviously, that's why you are saying it's malnutrition, for example. And you have height for age which is decreased, but weight for height which is almost normal.
This is tricky.
Correct. It is tricky because you cannot have a weight for age normal when there is height for age is decreased. Okay. The second one, you have everything is decreased, then you think about acute on chronic. Barabar? And in the last one, what Rajesh sir was saying about tricky is this one. Your height for age is decreased, but weight for height is increased. Meaning the weight is more than expected for the given height. Then what type of malnutrition is this?
Come on, think. Which one is faultier, denominator or numerator? Weight for height is increased. So correct. Which is faulty?
And what did we say first? 3 times I have repeated. For no reason I have kept that column of saying weight for age is decreased. And I haven't mentioned anything over here, right? It's not malnutrition. You have to think about endocrine causes, right? Because if your height is only decreased but weight is appropriate to the height, we are assuming there is no edema, okay, which could be falsely giving you the increased weight, then you are thinking about not malnutrition but think about other causes which may give rise to this problem. Now you have done all these exercise, you are experts, you are plotting your growth charts normal. But when will it be a red flag? When would you think that this is abnormal and refer a patient or investigate yourself further? So 3 important points you have to remember. If the child is less than 3rd centile or more than 97 centile, then it is abnormal. If lane cutting is an offense, so if you cut lanes, then that's the problem. If somebody is sitting at 5th percentile forever, you don't worry too much about that kid. But here you are crossing 2 major centile line, either downward or upward, unless of course you are treating. You have a malnutrition, you are treating and he goes up 2 centile lines, you are happy, then you are not worried. But you are not, your desired intervention is not there and he is going up or down, both ways you are worried. And lastly, we already discussed, even if the child is within the 3rd and the 97th centile, but he is outside of his target centile, then you would be worry about. Okay. There are some other markers which are not typically related to the growth. Is if you have any weight loss or no gain since birth in first 6 months, we are not talking about first 2 or 3 weeks, then you think it is abnormal. If from 6 to 12 months there is no gain, then you are worried about. And obviously, we don't look at the abnormal genitalia right now, we are talking only about growth charts. Now here if you see there is one more sensitive marker, the advantage of doing multiple tests. Your height has increased by less than 5 centimeters in the whole year. That should be a red flag by itself. Don't wait for that child to drop further down out of its centile lines, because this is what is known as the growth velocity. So if the growth velocity goes down, that is the more sensitive marker rather than actually them falling all the way out of your centiles. If it is more than 7 centimeters also, it is abnormal. We will not look at the BMI. And again, when we are talking about growth, we talk about puberty as well. So if the girl, this is again very generalized figure and there is a lot of variation than that. If a girl achieves puberty below 8 years or after 9 years, then you think about it as a precocious puberty. Or if there is no breast development by 14, no menarche by 15, or no male menarche by 16, then you start thinking about delayed puberty. Again, there is a range, and this figures I have put it only so that it's easy to remember. 8 and 9, 14, 15 and 16. Okay, this we already know, we don't get into that. You all have seen the various charts that you use. Important when you pick up a chart to see whether it is centile chart or an SD chart. Now when you pick up a centile chart, the lowest line will be the 3rd centile, but that will correspond to -2 SD, as you can see here. I don't know. Can you see here, this one? This is -2 and this is a Z score. So Z score is equal to standard deviation. You can see up there it's Z score written over there. So Z score is approximately equal to SD, and these are not centile line charts. -2 standard deviation is equal to 3rd centile. -3 standard deviation is equal to 1 centile. Okay. So it's important to know that. Now when you see BMI charts, you know that adult BMIs have single value, but pediatric BMI also changes as per the age. So you see these charts and you can make out this and this. These two correspond to overweight and obesity. Okay, the upper 2 lines, right? And when you have a special situation, you have special growth charts to use. We discussed whether it's a low birth weight child and you use Fenton's. You have Turner charts, you have achondroplasia charts, you have charts for Down syndrome, and you have some charts for charting SMRs and for charting bone age. It's good to remember when you have to chart bone age on a growth chart, you draw it as a triangle, vertical triangle, sitting triangle, and not as a circle. Whenever you mark anything on the growth chart, don't put a cross, don't put a round, put a dot. Okay, these are the standard notations which you have to use, and that is also because that avoids certain misinterpretation subsequently. Let's quickly look at, in 10 minutes, look at how does pattern of growth chart help us. This is just some examples of special charts I'm showing in case you have not seen them. You see some of the preterm growth charts. If you see down there, you can see that circle which has come up, this one here. So this will show you below 40 week gestation. So depending on what is the gestation age of the child, you will be marking the height, weight and length, weight and the head circumference along this line. And this one vertical line corresponds to 40th week post-conceptional line. You see further down, this says 24 months and this says 100 weeks. That's approximately 2 years. And why is this made for 2 years and not 5 years?
Do preterms catch up in growth or they don't?
By what time? Usually by 2 years, correct? So that's the reason which has been kept like this. Okay. So if you see here, this is the chart for Turner's, girls with Turner syndrome. Now you see these red lines on the top, this is the normal height or length chart, and this are the chart, this is the values which you expect for Turner's, correct? Why do you need that? You know they are going to be short, why do you want to monitor the height? Any thoughts on why do you want to monitor height of a child with Turner syndrome?
Anything additional they can have?
See, first is of course you want to make sure that they are not suffering from malnutrition, they are growing as per their normal potential. But also if you are treating them with growth hormone, then you want to see what is the response and whether they are doing better than a child with Turner syndrome. Okay? And same for achondroplasia or for Down syndrome. And we have charts for these conditions because there is a significant population of these syndromes for us to get normal values for them. Now this is a growth velocity chart. Sorry. Yeah. So this is the only growth chart which touches the baseline at the end. Okay. Because all your growth charts will go up except for this one. Now when you measure growth velocity, what normally you do is, suppose there is a child whose one reading you have taken at 5 years, 108 centimeters. At 5.5 years you have taken 111, correct? So you put one line at 5 years, you draw one dot, you draw the other dot, correct? In your normal growth chart. Here what do? Here you take the in between point of 5 and 5.5, correct? That's 5.25. At 5.25 you put a dot at, what is the difference? 111 minus 108 is 3 centimeters. So what is the growth velocity? 6 centimeters, not 3 centimeters. Because this is in 6 months, right? Your growth velocity is per year. So you extrapolate it to per year. So you get 6 centimeters. So you know 6 is written here. And you take 5.25 years here, then you take a vertical here and somewhere here. So this is where the reading will come for this. You understood or should I repeat it once? So just to quickly say that on the vertical axis, you make growth velocity per year and choose a point. In the horizontal axis, you take the midpoint of the interval that is the two readings are taken from. Okay. Now why are we putting so much importance is because this is something where you will get answers quickly. Normally the growth velocity is between 5 and 7. Okay. But if you see here, suddenly it goes up. First it slows down and then it suddenly jumps up and then it slows down again and becomes 0. So this is classically your pre-pubertal growth slowing, then there is a pubertal growth spurt, and then there is arrest of growth because the epiphyses are fused. Now why are these shaded areas are there? Because this is the normal puberty. But if the child has, suppose a growth velocity coming and this shaded area, then you look at him or her and see where is the SMR. If the child is showing signs of puberty and it is corresponding with your growth spurt, then you are all right. If they are not, then you still think there is some other endocrine cause which is causing the height to go up faster. Okay. Let's quickly do these 4 and then we stop. Okay. What do you think this is? Okay, sorry, I have put the answers. This happens sometimes. So important to know is what, see, that this child has, whenever you interpret a growth chart, no, 2 things you have to remember. What is the growth velocity and when is the onset of the disease? 2 things. Here, what is the growth velocity? Normal or abnormal? But this is not a growth velocity chart, no? How will you make out the growth velocity? Very good, excellent. So if your markings are running parallel to the centile lines, whichever centile line, that means your growth velocity is normal. So you don't need a growth velocity chart in routine times. This is a normal growth velocity because the child is nearly growing normal. Now here if you see, suddenly he has crossed lines. So there the growth velocity has gone up, correct? And the onset is almost since birth or somewhere around that. So you are thinking normal growth velocity means no major systemic disease, no major endocrine disease. You are only talking about deviation of growth. So deviation of growth, we have only 2 categories. One is constitutional delay and one is familial or genetic, whatever term you want to use. Now here, because we know that the child has reached the normal centile lines and there has been a jump later on, you will say this is constitutional growth delay, correct? So early deceleration and normal growth velocity, that is what we said. Okay. Now we look at this one. Here again if you see, the growth velocity is same, so normal growth velocity, but there is no catch-up growth, correct? So this is likely to be familial short stature. But if you are suppose you saw the patient here, you don't know whether he is going to catch up or not. So how do you make out it constitutional or familial? Very good, excellent. So you get history of delayed puberty in the parent, then you think about it, ask the parent whether they have had a late growth spurt, and finally you can do a bone age. Okay, if it is constitutional, the bone maturity will still not be matching with this. That means there is potential to catch up. If bone age is matching with your height age, that means they are both growing at the same speed and they will not have catch up. Correct? So that's likely to be familial. That's another way to look at it. Now you see this one. Growth velocity normal or abnormal? Abnormal. Correct? What is the onset of the disease? Very early. Correct? So if it's very early, that means either it's most likely a congenital problem or around birth, before birth problem. That means either you are talking about a congenital endocrine problem or you are talking about a genetic condition. Right? So here I have given an example. Maybe this is a Turner syndrome, because child was never normal and further there is a deviation of growth. Growth velocity is abnormal. This one on the other hand also has abnormal growth velocity, but the child was normal some point in time and then there has been a dropping off of the percentile. So what this could be? This could be a systemic condition, systemic disorder. It could be anything. It could be HIV, tuberculosis, Crohn's, malnutrition, or acquired endocrine disease. So acquired hypothyroidism or something similar to that, where the child was growing normally and now the height and weight and height has started getting affected. Okay. So we have realized 2 things. One is you have to check the growth velocity, and second you have to try and identify the onset of the disease. Once you have these 2, then you are reasonably sure on getting the condition or at least differential diagnosis on what it is. And when you intervene this one, you might get crossing of centile lines because it has been a successful intervention. Suppose it was Crohn's or celiac. You intervened, your child started gaining weight and height, and you will find it like this. Okay. This is the summary of the whole thing, but I will stop here. Any questions? We can take up the next part sometime later.
Any doubts, any questions?
Khandelkar has also made one chart which is very friendly for mid-parental height.
Yes.
You have on one side the father side, one side the mother side, and wherever the cross line is mid-parental. So he's trying to make it as simple as possible and as informative as possible. Though we have already known how to calculate mid-parental height, but the point is he has gone so much ahead to make it so simple. And what is the inference? Every child that you see anywhere must have a growth chart. And somebody must chart it, and somebody must interpret it, right? Yes.
Can I make some points? Growth charts are not popular. I found that BSc graduates do not understand our growth charts. One reason is we talk English. So if we make them simple, the information simple and in all Indian languages, everybody will be able to use them. And we have to make them. So I have made them in Marathi, Hindi and English. So if you want them, I can email it to you. Ask me on my phone number 9823281447. 9823281447 or email me on haj2007@gmail.com. haj2007@gmail.com. Number one. Number two, we have a nano vision of one child, but we miss the national vision. NFHS data 5 shows that on second birthday, 9 out of 10 children are malnourished. They have run down on the growth charts. We see that the school children, they grow 2 inches less in the school time. They don't grow 6 kilos and 6 inches every year. Number 3, as sir just now said, and our constitution gives us a right to live. A child has a right to live well and grow well. And for that, he needs a growth chart. So it is his birthright to have a 1 rupee growth chart with him. So let's give it to him. And there is a nice IAP app, growth chart app. So let's ensure that every Indian has that app in his phone. We have now, every family has a phone. Then they will see it themselves. Finally, in school, they teach them charts, but they teach them how cattle grew. Instead, they should teach how children grow. So child's growth chart should come as a lesson to teach charting. That will make India good. Thank you.
So we end this class here. So thank you all our online friends who are watching and our online faculty who contributed. Thank you very much.
Sir, one line. I just want to tell you importance of this class. There is a local importance that the students who attend here, they learn. But there is a national importance that 1,000 people attend this. And soon this will be global. So let us all ensure that all of us attend and tell all our friends to attend. Thank you.